I'm very excited to have the opportunity today to talk about our work regarding emergency Medicaid programs. I'm hoping that we could frame this in the context of a broader lecture on understanding the multiple domains of access to safe and equitable surgical care, and then more specifically to identifying barriers in access to care related to lack of health insurance. And then we'll hone down on the role of emergency Medicaid programs in improving access, and specifically a program that we've been studying called hospital presumptive eligibility. I have no conflicts of interest and my funding is as listed. So a little bit about me. Dr. Forrester covered most of this, but I grew up in Canada, in Montreal, and went to McGill University for medical school, and then moved to the beautiful city of Vancouver, British Columbia, seen here on the upper right of the screen. If any of you haven't been, I highly recommend a visit. So it was here during my residency at UBC that I met my program director, Dr. Morad Hamid. In addition to inspiring me to become an acute care surgeon, he also recognized in me my passion for health policy and thinking about health system challenges at a very broad level. So during my professional development time, he encouraged me to pursue an MPH. So off I went to the Harvard Chan School of Public Health, where I spent 2 years. And this was actually a very exciting time because global surgery was kind of growing into a field of its own, independent of global surgery, and very important landmark papers were being published on the lack of access to safe and equitable surgical care worldwide. 5 billion people not having access, resulting in deficits in surgical procedures, as well as tremendous loss in global productivity. So I was really fortunate when I was there to work with and learn from some of the experts in the field, and some of served on the Lancet Commission for Global Surgery. And this paper is over 10 years old now, but I think it still has a lot of broad applicability. And I want to take a little bit of time to go through some of these access to care that they discuss here, because I think there's applicability across healthcare settings, and it's something that I refer back to constantly in my work. So if you think about accessing surgical health services, the first kind of pillar in this is timeliness. And in trauma, there's a few trauma surgeons in the room. We always talk about the golden hour of trauma. And global surgery context, we like to say that, you know, for urgent conditions, we want to have patients reach the nearest facility within 2 hours in a timely fashion. If you think about this on a global scale, there's a number of things that could impact this, such as weather conditions, political unrest, access to motorized vehicles, or even if we think about locally, you know, helipad transport, et cetera. And then once you actually reach that facility, does that facility have capacity to provide surgical services? So by this, I mean anesthesia and surgical providers, nursing, perioperative services. Do they have basic equipment such as O2 sats and ventilators, emergency services and blood supply, and things like electricity and running water? So all of those things kind of work together to provide surgical capacity. And then if you talk about the next pillar of safety, I would argue that if you don't have any of those factors in the capacity realm, you really aren't able to provide safe surgery. So let's say that you achieve all of these things. The last pillar that they talk about is affordability, and whether a patient can obtain such surgical services without causing catastrophic health expenditure and bankrupting them. And this is something that I would come to focus on a little more recently in my research career. So my time in Boston was very productive. In addition to earning my degree, I did some field work in Liberia and Haiti, and this led to some multi-institutional collaborations, both with institutions and some universities in these countries. And we focused mostly on creating and implementing surgical capacity survey tools at the time that were meant to improve things like infrastructure, supplies, personnel, and equipment. My takeaway from this time was that there was really such tremendous variability within countries, which we'll see also in the US, as well as across countries. And really these complex patterns of healthcare inequity emerged, which led me to question, what is the safe and equitable standard? I would later go on to publish this paper with Dr. Weiser And I was very fortunate to connect with him when I was in Boston many years ago, and now lucky to call him as a colleague. But we worked on this paper looking at that Lancet Commission goal of safe access to surgery, and we used GIS mapping across a number of countries. I just pictured here as an example, Liberia and Bangladesh. So if we use that Lancet Commission goal of 2-hour access, we see the areas in blue and then a little bit in yellow are areas that people in the country where people can access care within that 2-hour frame. But then again, using GIS standards and road traffic conditions, we applied some of these minimum safe surgeries, also been discussed in prior literature, and you see that the access to care drops dramatically in these countries. So from nearly 80% in Liberia down to 30%, and in Bangladesh from nearly 97% down to 50%. And I would argue that access to surgery decreases even further when you talk about more recent concepts such as quality and health equity. So for those of you who did research time, you know that it comes to an end all too quickly and you have to return to residency. So I did just that. I went back to Vancouver and finished up my residency. And then I was very fortunate to match to Stanford for surgical critical. And it was at this time, coming from a universal healthcare coverage model, that I really started to focus on that last pillar of affordability and access to care, because I found myself wondering, how could we provide the most state-of-the-art, high-tech medical care to our patients? And then just down the road, we see images like this in the lay press, and we read articles like this. So then I started to focus a little more specifically on US surgical disparities. And I think a lot of the same concepts that we've already discussed in the global scale apply here locally: sociodemographic and healthcare resource and utilization. But I'm going to focus the rest of this talk a little more specifically on something that's unique to the US system, and it's our insurance models. And this is something that is very timely and very pressing. Deloitte, which is a consulting firm here in the US, did a recent modeling of the cost of health inequities, and it's estimated to be about 300 billion right now. And by 2040, this is estimated to be up to $1 trillion. So this is a pressing problem that requires an urgent solution. So again, going back to this pillar of affordability and access to care, I think everyone in this room probably recognizes potential benefits that insurance can provide our patients. But just to recap some of the recent literature on this, we know that lack of health insurance, not only across surgery, but across all medical disciplines, leads to worse access and outcomes for our patients. We're actually at an all-time low in terms of the number of remaining uninsured population post-COVID, but that is about to change with the omnibus bill. Some of you probably heard about this, but the continuous Medicaid enrollment that was instituted during about to be repealed selectively across the country. So we have about 10% of the uninsured population residing here in California. So it makes it kind of an excellent grounds to study this. So these patients have higher rates of mortality and worse trajectory. They're more likely to forego care, as we know. They have limited access to post-discharge resources. If any of you have been on the trauma service, you know that many of our patients sit waiting, for their insurance provider to accept them to rehab facilities and whatnot. And they're also less likely to seek preventative care. And this is particularly important for racial and ethnic minorities, which have an even higher likelihood to have low income, be underinsured, and worse outcomes. And I think it's really important to note that there's very serious sequelae, not only for patients, but for the hospitals treating these patients. And we often call them safety net hospitals because their mission is to serve primarily the indigent or the underinsured population. So if you think of many of our county hospitals here in California, so we know that about 70% of uninsured patients are unable to pay for their health care. And it leads to this concept that we talk about called financial toxicity. I'm going to take a little bit of time just to give some background on this. This is a paper that a couple of years ago, and we looked at a very large national private insurance database, had great employer-based insurance prior to their injury. And as we know, injury is unanticipated. And within that year following their injury, up to 50% of patients either churned on to another type of insurance, so a government program like Medicaid, or they lost insurance altogether. And this risk increased significantly with. And if you think about these same patients who still, who have private insurance at the time of their injury, even they are faced with significant out of pocket at the time of their injury and then in the follow-up. And many people are subscribing to higher deductible plans right now. There's been a steady increase in this, and we also correlated with out-of-pocket costs and catastrophic health expenditures. So we've done a great job in the past quantifying some of the direct costs like out-of-pocket expenditures and things like income loss for patients after a major health event. And this can all be grouped into something that we call objective financial burden. But this is actually a paper out of the cancer literature that we're really only now beginning to adapt in the surgical literature, talking about subjective financial distress. So what is the psychosocial and kind of family repercussions and the stress that is involved financially for patients once they have a major health event and maybe lose their job, have impacts on things like their credit scores and whatnot. So all of these things put together lead to this concept of financial toxicity. And then just focusing on the hospitals for a second, since 2000, we have about $650 billion that we've spent in uncompensated. That means treating patients who can't pay for their care because they're uninsured or underinsured. So this has resulted in some of the tremendous debt and healthcare expenditures that we have in our US system. This is a paper that we wrote a few years ago with Dr. Stoudemire looking at safety net hospitals across the state of California. And you could see the dramatic differences in the hospital net income and operating margin between those providing care to the underinsured versus the non-safety net or private hospitals. We actually did a pre-post analysis, kind of post-implementation of Medicaid expansion, and we saw that even though there were negative margins in these public safety net hospitals, there was a fairly steady improvement. Largely attribute that to an increased Medicaid or Medi-Cal, which is the California version of Medicaid payers, and a subsequent decrease in county uninsured patients. So I see a few people who research Medicaid in this audience, and I think it is an imperfect solution, but it plays a very important role in providing needed insurance coverage in our country. We can't ignore that 1 in 5 Americans are covered by Medicaid, and it covers about 20% of US personal and health system spending. So this is why it's really important to study it and see how we can maximize the benefit of such programs. So at this stage, I was really starting to recognize the need to identify programs not only targeted at acquiring the insurance, but helping patients sustain that insurance coverage and prevent that insurance churn. So if we look at the phases of health disparities research, I think in the last 2 or 3 decades, we've spent a lot of time in the detection and understanding kind of these descriptive phases. And I would urge all of you as health services researchers to really start to try and shift your work into this reduction phase. And this is what I'm trying to do, and evaluating and translating some actionable policy change. So I started wondering, what if there was a way to help patients acquire insurance when they really need it, urgent health event, and be able to sustain it afterwards? Well, it turns out that this program actually exists, and it's happening in our hospitals, including Stanford, but we just don't really talk about it very much as healthcare providers. I started reading about this in the health policy literature more so than the clinical literature, and then really started researching it locally with our trauma patients here, saw how the tremendous opportunities that were associated with it. So this is essentially a hospital-based program. It was enacted fairly recently with the Affordable Care Act across all states, but then there's variability across states in terms of eligibility criteria and how broadly applicable it is. The way it works is that uninsured patients come to our emergency department. They actually get screened by financial counselors or social workers to help them at the time of hospitalization, and then they fill out an application for this temporary, and they are potentially approved and granted coverage for up to 60 days. So this is meant to increase their access to healthcare services. For example, if they need to go on to their next phase of care at an acute rehab facility, SNF, et cetera. And then it's also importantly meant to offset hospital costs. The review of the California HPE eligibility criteria, and I think we've been very fortunate to be able to study this program of policies across the country. Essentially, the main restriction is income limits. You have an income limit below the monthly limit for your household size. So for example, you can't be a billionaire in Silicon Valley and say, oh, I'm self-pay, but then benefit from HPE Medicaid. You also need to be a California resident, not on any other type of insurance. And this benefit is really only eligible once a year unless you're pregnant. So as you can see, it's applicable to most adults age 19 to 64, but then it also has some clauses for children and foster youth, as well as caretakers and patients who are pregnant. So really, there's no real age restriction. The 65 and over patients usually funnel into Medicare. So I started thinking, HPE could actually be a very promising program for the uninsured, but how do we go about studying it and which populations would potentially benefit from it? Since there really wasn't a data set to study this, I knew that I had to start locally within our institution. Being a trauma surgeon and knowing that trauma patients are twice as likely to be uninsured as the general population, I decided to start there. This is just a nice conceptual framework that summarizes a lot of the concepts that we've already talked about today by John Scott, who's a fellow researcher out of Michigan. So what we did was an extensive chart review at Stanford, both using our trauma registry and electronic medical record. 2015 post-ACA to 20. And we performed an extensive chart review of financial counselor text notes. So this was very late. All patients aged 18 to 64 with a diagnosis of trauma. And the primary outcome that we were looking for was HPE approval. We ended up reviewing about 2,300 free text charts to determine the insurance status at admission and the factors influencing HPE approval. So we see here that Stanford actually does a really good job at screening patients when they come through the ED. So for the self-pay group that you see on the bottom, 86% managed to be screened. Actually pretty impressive because the financial counselors only work until midnight. So there is a period of time between midnight and 6 a.m. during which, as you know, a lot of our trauma patients come through the door where they're potentially missing screenings, but they've been able to capture a fairly high rate. But really only about 50% a few years ago were actually getting HPE approved. So we wanted to know what are the factors that are sort of, facilitating approval versus some of the barriers. So looking at an unadjusted analysis, the HPE approved group was more likely to be severely injured, have an inpatient admission or an ICU admission, have operative intervention, have longer length of stay, or require discharge to post-acute care. And then in our adjusted analyses, we see that there was some positive effect if you were of a minority ethnicity, if you had operative intervention, or if you had a higher injury severity score. And then we wanted to understand, this is the 14% of patients who weren't screened, but these are the rest of the people who were. For those who were screened and had an application filed, why did they not actually get approved? So about 35% were over the income line. And then surprisingly, 25% actually refused, were unable to be contacted. They were lost to follow-up. Some patients were non-residents of California, and then some had already benefited from the program in the prior year, or they said that they were uninsured, but in fact, they had some type of insurance coverage, and all miscellaneous issues like technical glitches with the system. We knew that we needed to get a little more granular if we wanted to understand some of these barriers. So then we embarked upon the qualitative phase of our study and conducted semi-structured interviews with hospital stakeholders here at Stanford. So case managers, financial counselors, social workers, and some third-party company med data representatives who actually help our Stanford personnel with this process. So some of the things that we were able to identify at the patient level were inability, as you would expect, to communicate with patients due to illness or being unable to contact a next of kin that would provide them with the information. Severe knowledge gaps regarding the potential benefits of insurance, cultural and language barriers that needed to be addressed, reluctance to disclose personal information, and perhaps this was related to documentation status. And then there were some system level barriers that could be improved upon, such as lack of adequate training of our staff, short emergency department stays, limiting patient contact, and technical challenges with the HPE portal. So some of the opportunities identified from this were improving the personnel's training and staffing, as well as providing a patient with educational materials, as well as conducting better patient outreach. These are just some select quotes that I wanted to include, and you could see the scope of the problem here. This is one from a social worker. It's important to educate case managers and social workers on the processes and application times more regularly. I think we were probably trained when we first came in, and then there's been no follow-up. Also, educating the rest of staff, including physicians, on the process is effective. And I think this is really important because we as physicians never really talk about this, and this could potentially be included in things like our multidisciplinary rounds. So we owe it to ourselves and to our patients to be a little more educated. And then this is another really poignant quote. I did have a family that just straight up refused to bring any information forward. That patient was from Mexico and living here less than a month, didn't have insurance, and got into a horrible car accident. They were just really afraid to provide any information. It was maybe 2 or 3 weeks after they were hospitalized that they started to trust us and know that we were working in their best interest. So if we go back to the things that kind of facilitated HPE approval, longer hospital stays, certainly not advocating for that, but you could see that it really takes time to build up this rapport with patients and get them to trust you to kind of disclose this very personal financial information that's required for these applications. Another really important thing that we learned from our interviews is that we talked about this temporary HPE Medicaid that patients can have for up to 60 days, but there actually is a way to sustain Medicaid after this for the long term. So once you have HPE approval, these same staff work with patients and encourage them to apply for full scope Medicaid, and this will provide them with long-term insurance. This can actually be done at the time of hospitalization. So they're also educated to help patients and family members complete the connect to applicants. We do a really good job of this with county Medicaid representatives, or again, these third-party vendors like MedData who help. And then you could see if patients are admitted potentially for a more complex course, they have a greater chance of. So now that we had studied this locally at the trauma patient level, we knew that we wanted to study this kind of across surgical and medical disciplines. We wanted to scale this work, but there was really no administrative or clinical data set that accurately captures a patient's true insurance status. And that was a really big light bulb for me, because it kind of tells me that a lot of the disparity studies that we're publishing on are potentially a little bit inaccurate. For example, if a data set captures expected payer status at the time of discharge, so say they leave the hospital as Medicaid, that's what will show up in the data set, but that patient could have come into the hospital as uninsured and had a change in their insurance status during their hospitalization. So that's not really reflective of the truth, and that's why it requires this kind of retrospective detailed chart review. We wanted to know what happens to patients after HPE, so this temporary Medicaid approval, do they go on to sustain it? So we knew that we needed to track patients longitudinally to outcomes. We were really fortunate. We had some funding from the Stanford Surgery Seed Grant, and we had been in kind of longstanding conversations with the California Department of Healthcare Services. And then it really helped that we got some funding from the NIH. We were able to collaborate with them, and eventually they built us a customized longitudinal data set of all the California HPE recipients that we could follow them, a year out and see if they still had insurance. So this allowed us to really scale our work. This is just a brief overview of the HPE applications and the number of approved HPE enrollees per month between 2014 and 2019. And as you can see, there's a fairly steady increase in both applications and approvals during that time. And then we also noticed some really interesting variability that warrants for further investigation. This is just an example heat map of Southern California, but you see the HPE participating hospitals in purple and non-HPE hospitals in blue. And hospitals in zip codes with the highest rates of uninsured patients are more likely to participate in HPE. That makes sense. But then there were some other interesting findings, like despite serving the same zip code areas, there were some hospitals that were next to each other that were similar in size and ownership, and some participated in HPE and some do not. So that tells us in our future work that we need to go out and talk to these sites and see what some of the barriers might be. Did find though that among the HPE participating hospitals, not only the patient's hospital services, but their post-discharge services for up to 60 days were more likely to be paid by Medicaid, and this quite significant. So going back to our customized data set from the DHCS, now we were able to study about 230,000 instead of 2,300 HPE beneficiaries over the span. You could see that this is pretty consistent with most data sets. A lot of patients come through the emergency department for their emergency or discharged home. So 70% HPE beneficiaries were ED encounters, and then 30% were inpatient. But interestingly, when we looked 6 months down the road to see whether these patients still had insurance, 2/3 of the inpatient people had Medicaid, whereas only 1/3 who came through the ED for a very short visit actually sustained insurance. And then we wanted to see really which of the emergency populations clinically HPE Medicaid is benefiting most and how likely they are to sustain coverage. So we were pleased to see that traumatic injury was among the 5 most common categories. And interestingly, emergency GI, general surgery, are also up there. So if you think about biliary colic patients, appendicitis, things like circulatory and cardiovascular disease, infections and sepsis, as well as mental health and behavioral disorders. So just targeting these 5 groups, I think there's tremendous opportunity for improvement. Looking at the Medicaid sustainment 6 months down the road after HPE approval among all these groups, that you see that among all comers, about 2/3 of patients actually stay on insurance, which is more than I expected and fairly promising. Some of the higher rates of sustainment are in the trauma group, interestingly, but all of them are faring pretty well. And again, looking at the likelihood of sustaining Medicaid, this is in the broader group, you see that patients are more likely to sustain Medicaid if they have some type of surgical intervention. They have ongoing healthcare needs, like a need to discharge to post-acute care, and if they have longer lengths of stay. They were less likely to sustain Medicaid if they were non-English first language speaking, such as Spanish. There was also a group of patients that declined to state race, language, and ethnicity, and they were very unlikely to sustain. And then if you were discharged on a weekend, you were less likely to sustain as well, which suggests some potential opportunity for improvement. These are just some more graphs that we're working on showing some of the variability, both at the inpatient and outpatient level, as well as the hospital and county level. So you could see tremendous variability in Medicaid sustainment. And then even within a single county, it really kind of matters about the size of the hospital, type of ownership, and whatnot. We see here, this is really fascinating, that across California, the likelihood to stay on insurance after this HPE program varies significantly based on what county you're in. So we actually do quite well in the Bay Area, but there are some counties with sustainment rates as low as 30%. So again, future plans for our work are really going to be kind of doing those focused interviews in some of these lower performing counties to identify some of the barriers. And then I see Tom Hanley in the audience. This is something that he just recently published. We were really interested in looking at what the impact of COVID policy changes were on this HPE program. So as we know, about 12 million patients were left without employer-based health insurance due to job loss due to COVID. So in March of 2020, California actually implemented a public health crisis HPE policy change that the number of HPE approvals per year to 2 from 1. And they also enabled some remote and telephone approvals for patients no longer hospitalized. So we wanted to see what the potential impact of this was. Just looking at our Stanford data, we see that there was a small increase. Again, our rates were already pretty high in the screening, but I would say there was a significant increase in the number of HPE approvals. It went from a lower number of 48% that we talked about earlier to 61% now. And COVID-19 was associated with likelihood of HPE approval of 1.64 adjusted odds ratio. So I think the impact on Medicaid sustainment is TBD because they're just kind of gathering that at the state level now. So that'll be something really interesting to study. And it'll also be really interesting to see whether they actually keep these expansion policies in place or revert to the old. To wrap up, I want to talk about some of the current things that we have going on and some of the next steps. So similar to how we interviewed providers, the next phase of this is that we're going to be conducting local HPE patient interviews here at Stanford and hopefully over at Valley and a couple of other sites. As we know, the literature is evolving and patient-reported outcomes are really so crucial to the work that we do, but they're extreme, particularly in this underinsured patient population that can be a little difficult to follow. We really hope to better understand some of the barriers in process, such as this fear of disclosure, loss to follow-up, some of the paperwork burden associated with this process. And we have an R01 currently under review that's awaiting a funding decision. And for that work, we're going to be studying, again, at a kind of broader state scale, HPE and Medicaid sustainment changes with COVID, and then the upcoming legislature changes I discussed. We also want to evaluate some of the longer term healthcare access and utilization when people go on to sustain after HPE. Does that mean that they're having more routine and preventative care visits, fewer emergency department visits? So that's something that we're going to look into. We'll also be engaging with hospitals across California to understand some of those variabilities that we saw in the maps in prior slides. All of this is going to require an ongoing partnership with DHCS, and the ultimate goal is to develop a best practice toolkit, which eventually will be pilot tested and implemented across lower performing sites in the state. Ultimately, we hope to streamline the system so that even patients with shorter length of stay or emergency department visits have a greater chance of approval success. And I think it's going to be really important to study this program, not only in California, where we're doing fairly well, but across states that have significant eligibility variation. So I'm going to present some conclusions here. They're interim ones because this work is ongoing. But I think HPE really can be a promising pathway for Medicaid insurance coverage for our patients. And particularly, we've seen that it's really important among clinical populations that require surgery. So this is very relevant for our surgical patients because they often do need repeated healthcare visits after their operation and ongoing access to care. And I would argue that there are opportunities both at the hospital level, but then individually as providers to directly impact patients' access to care and change their post-discharge trajectory, with something simple like education and counseling. So in summary, I think the road to accessing equitable, safe, high quality care is undoubtedly a long one, but I think it's full of promise. So thank you very much. And I just want to thank all of my research team. Hopefully I included everyone here, people over at S-SPIRE, some postdocs, residents in the Department of Surgery, medical students, and very grateful for the funding from the Department of Surgery and the AAST, which stimulated some NIH, our ongoing work with the state. I welcome any questions.